Jill Bond has sent her apologies. Dale Rook has sent his apologies. We welcome Louise Brown in place of Malcolm Lane. Anybody else? I think that's probably it now. So we'll start on. So I will introduce myself. I'm Penny Jones and I'm chairing this meeting today in place of Armand Watts.
Hazel Eilert, Scrutiny.
Maidan Howells, Ward Councillor for Llanfairpwll and Usk.
Councillor Louise Brown substituting for Councillor Malcolm Lane. Thank you.
Tony?
Councillor Tony Keir, Joint Ward Member for Llanfairpwll and Usk with Maidan Howells.
Right, thank you. Sue?
Sue Riley, Joint Ward Member for Bulwark and Thornwell. Thank you.
Thank you. Stephen, sorry, you're a committee member, so I should come to you next.
Steve Garrett, Overmono Ward in Monmouth.
Right, thank you. Angela?
Good morning, Angela Sandals, Joint Ward Member for Mega East with Undy.
Thank you. John?
Yeah, John Crook, again, Joint Ward Member for Mega East and Undy.
Thank you. Alistair?
Good morning, my name's Alistair Neal. I'm the ward member for Gobi and Var.
And Phil?
Morning, Phil Murphy, member for Coent.
Right, thank you. And now we'll, perhaps our guest speakers could now speak.
Me as well, Penny.
Oh, Anne, sorry. You're not
I'm the member for St Arvan's Ward. Good morning, everybody, which encompasses Andogo, Tinton and St Arvan's. Thank you. Thank
you. You've disappeared, but thank you for being there. That's lovely. Right, Lloyd, would you like to introduce yourself, please?
Yep, thank you, Penny. So my name is Lloyd Hambridge. I'm the Divisional Director for Primary Care, Community Services and Long-Term Chronic Conditions within an Aneurin Bevan Health Board.
Thank you. And Rachel?
Morning, everyone. I'm Rachel Prangley. I'm the Head of Primary Care in an Aneurin Bevan Health Board.
Right. Thank you very much, everybody. Right, declarations of interest. I have a declaration of interest. It's a personal interest. It's not prejudicial, and that's with the advice of the legal department, as I am a member of the independent member of the Aneurin Bevan Health Board. Anybody else got any declarations of interest? No? As and when?
Penny?
Yes.
Penny, yeah, I just declare a non-prejudicial interest. I work for the NHS Wales.
Right. Okay. Thank you, Alistair. Right. There's no public forum today, so we'll get on with the next session, next item on the agenda, which is dentistry. And as you know, there've been we've had sessions before on this. With many questions, but we've had a very detailed reply and report, which you've all had, not only in your minutes, but in an update to Steve Garrett as well. And I just wondered how you wanted to do this. Lloyd, do you want to come in and just say a few things at this point about any updates or anything you want to add, or do you want to go straight in with questions? What do you want to do?
So I think I'd probably just give a very brief update, probably on one or two points, if that's okay, and then open up to questions. Are you happy and content with that, Chair?
That's absolutely fine. Thank you.
Perfect. Okay. So in terms of updates from the November session that we held, I'm not going to necessarily go into the detail significantly, but just to sort of reiterate a couple of key points and then provide a bit of an update, particularly around the dental access portal that we discussed in our last visit to this forum. So Aneurin Bevan University Health Board, we are obviously responsible for the provision of general dental services via the general dental contract across Aneurin Bevan. So we currently have 74 general dental contracts within Aneurin Bevan, and within the Monmouthshire County there are 9 which are currently in place. In 23 to 24, the Health Board and the services that are commissioned saw over 340,000 patients within the dental practices, which and of that, there was 94,000 were children. So it is approximately a 15% increase in the total number of patients seen compared to the year of April 22 to 23. As an update, so from April of 24 to January of this year, so 25, there's been 272,000 patients who have been seen within dental practices across the health board area. And in terms of the children element of that, 77,000 were children. In terms of probably the biggest update to make, which is in relation to the dental access portal. So we talked previously that health boards across Wales manage routine NHS general dental service accesses in different ways, with some patient lists being held by health boards and others being held by individual practice level. And there hasn't been a central process in place for patients to be able to sign up with an NHS dentist for routine appointments. And equally, there's been no regulatory requirement for practices to hold a waiting list either. And Aaron Bevan University Health Board has not traditionally held a central waiting list either. Now, because of this inconsistent approach across Wales, Welsh Government has been working with health boards to be able to introduce a centralised platform that be able to support this. So this is what's known as the Dental Access Portal. It is a portal that's designed and built by Digital Health and Care Wales, or DHCW. So it's a centralised digital service, and it allows patients in Wales to access the NHS dental services on a more equitable basis. Now, when we spoke last, we advised that there was a launch on the 20th of November of the platform. Unfortunately, there was a pause then that was instigated by Welsh Government as a result of working through issues associated with the informational governance of the platform. As a result, that has been paused up until current time. So we have now got a new go live date for an Aaron Bevan University Health Board as being the 12th of February, so 2 days from now. And that is going to be a full national rollout of the dental access platform from that date. So we are working as a health board with colleagues in Digital Health and Care Wales on this rollout, and we will be working with our communications teams as well as our patient population to ensure that they understand what that rollout means, how they can access the service, and how we can signpost our patients to NHS dental practices that have the capacity to accept patients. So we are hopeful that this platform will allow for better understanding of demand both locally and nationally. So as a health board, to help us understand what the demand is for NHS dental care, as well as nationally then for Welsh Government to be able to understand and appropriately support future service planning, which hasn't been the data available to us historically to be able to make clear, informed, needs-based assessment in terms of what the future service plans will be. So I wanted to give a brief update in terms of those points. Probably the only other element that I do wish to flag really is we talked previously about the Health Board receiving a ring-fenced recurrent allocation for the Commission of General Dental Services, and we have been looking at opportunities where possible to provide additional funding into the system. So we have taken an opportunity as part of the Tregear Health and Wellbeing Development, or the Bevan Centre development, with an additional investment of nearly 300,000, and that's been instigated since 23-24, and as well as into this financial year. And we are now progressing the further investment of part of the Newport East Health and Wellbeing Centre, or the 19 Hills Health and Wellbeing Centre development, and that is in the region of £286,000 as well. It's going to be inputted into that. So I'll stop there if that's okay, Penny, because and similar to our previous sessions, I'm more than happy to share sort of updated report with colleagues here, so they can have any updates that was from the comprehensive report that was provided in November.
Thank you, Lloyd. That's really helpful. For those of you who are just observing or not a member of the committee, you can ask questions, but you will be brought in after the committee members, if that's all right with you. So by all means, feel free, but can you use the raise hand in the chat bar, please, to put your hand up. Right, first of all, we have Marion Howells. Thank you.
Thank you, Chair. Thank you, Lloyd. Thanks for your presentation and update there. I've got a few questions. I've got 4 questions in total, actually. Some are quite easy. The first one is, in view of the population increasing on average about 1% per year, and the fact that newly qualified dentists are in the majority now, a reverse of previous trends, and are female, we are looking at potentially that some of these qualified dentists will be leaving the profession briefly to have children, and possibly coming back to return to work, but only on a part-time basis. So my question is, what specific steps is Aneurin Bevan taking to address the declining NHS dentistry workforce beyond simply increasing recruitment numbers to ensure long-term retention and job satisfaction for dentists? My second question is really just an update of NHS dentistry for children and those on low incomes, as well as the waiting times for treatment. Is that improving? And do we have any data on the county-wide population of dental health? Is there a rating as such, that we can say that on the whole county dental health hygiene is good or bad? And finally, I was at the presentation last week and met you there, Lloyd, and just wondered if the new health centre, medical centre at Osbaston, are you considering putting a dental service in there as well? So just those 4 questions. Thanks, Lloyd.
Thank you very much. So I'll try and address those in turn if I can do, and I have, I think, written the 4 down, so if I do miss one, please do come in and just let me know. So first question then was associated with population increases, as you note then, in terms of the demographics of the dental workforce, and what the plans are in terms of supporting and ensuring that we do have adequate provision in terms of dental services going forward. So a few points to note first of all. So within NHS Wales, we do have an organisation that operates, which is called Health Education and Improvement Wales. So Health Education and Improvement Wales have a number of factors that they are responsible for, and part of that is ensuring that we are developing the workforce that we do need for the future. So we, as a health board, have contributed and provided information into Health Education Improvement Wales for the development of what's known as the Dental Strategic Workforce Plan. So the Dental Strategic Workforce Plan has been really a partnership with health boards, with dental professionals, with other stakeholders as well, including what's known as a strategic programme for primary care. And what the workforce plan has done is taken into consideration oral health and dental services, as well as the response to A Healthier Wales, which is the government's policy direction in terms of health and social care across Wales, as I'm sure you're all aware. And it's tried to work through then a plan that will be able to provide sustainable solutions for the future of the dental workforce in Wales. So it has predominantly focused on general dental services, so what we're talking about today, so commissioned dental services, but it also does highlight some key areas around the wider dental workforce across the whole system, so community dental services as well. I'm happy to share the details of the report as a sort of an additional point following this meeting, if that would be helpful, but it does have a series of elements associated with it. So one is around how we ensure that we are making the NHS within Wales an attractive ask for dental practitioners, because aside from the population variations around female versus male workforce, etc., as you mentioned, there is also the competing factor of private dentistry as being an option for our dental practitioners. So we are working to try and ensure that they do have access to NHS terms and conditions, which are in broadly favourable terms and conditions that will be supporting individuals to work within this area. But also we are developing community networks close to the areas in which they work. So these are called dental collaboratives. They're in their early phases at the moment, and we have already got up and running GP collaboratives and community pharmacy collaboratives all together. And what they do is they work, they bring together the community of practitioners in dentistry to be able to work through potential solutions and challenges within the local health board, but also around opportunities where they can be able to support each other as well. So we are working through that strategic workforce plan and trying to identify any potential opportunities we have to work with them. We do have within an Iron Bevan University Health Board what is known a primary care academy. So the primary care academy has a number of roles, one of which is to ensure that we are trying to develop and maintain our workforce for the future. Dental does play a part within that academy, and we are working to understand some of the needs of our dental teams to ensure that we're able to continue to ensure that that work is provided. And in terms of your second question, which was, correct me if I'm wrong, but was associated with an update in terms of children and those with low incomes. So I talked a little bit in terms of the number of children that had been seen across the health board area. So since April of 24 to present, there's been 77,000 children that were seen as part of our dental services. And in the totality of 23-24, there was 94,000. So we're on track, if not going to exceed that number by the end of this financial year. When we met previously, I talked about the contract reform programme, which focused its needs really on outcomes of individuals through what's known as ACORN, so the assessment of clinical oral risk. And what we're finding is that is then enabling the right patients to be seen in the system, and importantly, the right number of children to be seen and the right frequency for children to be seen to work through the programme. We, as part of the wider dental services that an Iron Bevan Commissioner and provide, we do have a community dental service within an Iron Bevan University Health Board. And this has a number of elements, but some of the core services that are associated with it is programs for children in special schools and units, looked after children, as well as adults with learning disabilities or severe mental illness or physical conditions, and or those with who are unfortunately homeless or affected by substance misuse and or vulnerable old people. So they deliver specific dental services to these cohorts of patients, and they are also involved in oral health promotion with these patients. So in terms of a specific element of that, we do have a Design to Smile programme. So this is a national oral health improvement programme, and it's delivered by our community dental services. And there's a number of elements. So one is around toothbrushing, and this is delivered in partnership with teaching staff at preschool nurseries and Key Stage 1 in primary schools as well. It focuses mostly on the deprived areas within our health board, so those within the Welsh Index of Deprivation of 1, 2 or 3. In Monmouthshire itself, there are 12 eligible settings for the primary school element. 10 have consented to take part in the programme, and of that, there are 770 patients who have benefited within the primary school area. Within preschool, there are 16 eligible settings within Monmouthshire, 12 settings have consented to take part, and 250 children have been in receipt of that activity. The last bit then around the Design to Smile programme is around fluoride varnish activity. So this is a varnish that's added to teeth to prevent and minimise the risk of dental caries. So within Monmouthshire, there's been 11 eligible settings, 10 have consented to take part, and thus far 465 have had the first application applied. So I hope that's a bit of an update just in terms of children, and obviously that service, as I already mentioned, covers off our low income and vulnerable groups as well. In terms of your third question, Marion, which I believe related to sort of an update in terms of the countrywide health of our population. So we do undertake a population needs assessment as part of the work that we do within the Health Board, and that really helps us to support the delivery of our services across and Bevan University Health Board, and that would include the dental services that are available, but also the impact of the dental position within our communities. I am more than happy to sort of, again, update and share some information on that, so to give you a link, etc., to the information, so you can have that in more detail. And then apologies, but I haven't got the last question written down. Do you want to repeat that, sorry, for me?
Thanks, Lloyd, and thanks for those answers. The final question was just on the Osbaston sort of new medical centre that's planned there, and whether or not there's any consideration for a dental surgery in there.
Yeah, apologies, thank you. Yeah, so at present there is no plans for an additional dental facility to be included as part of that centre. There are a number of reasons for that. So one is around the capacity within the proposed development to be able to put in a unit. So the dental facilities do require greater space due to the level of equipment that are associated with it. So there is an issue associated with that. Also, we do look at the plans around the dental provision within that area, and at current plans and processes that we are not identifying a specific need within that over and above what is currently provided. But as you're aware, the development is in its early phases of proposals, and we'll be working through to understand if there is any future opportunities around additional services that could be brought in.
Okay, Mary.
Yeah, many thanks, Lloyd. Thanks.
Thank you very much, Lloyd. Tony, I'm going to bring you in before Alistair because you're a member of the committee. Thank you.
Thanks, Penny, and thanks very much, Lloyd, for that presentation there. I've got a number of questions. Is it easier to answer them one by one, or just throw them all out at you?
That's fine. If you throw them out, I'll make sure I try and write them down this time, so we can go through each in turn.
First question, looking at the previous set of minutes and your comments you made earlier, you referred to Monmouthshire having 9 dental contracts now. The previous minutes referred to 10. So is that just a discrepancy, or have we lost a contract in that regard? One of the key things when any public services we're looking at where there are issues is the redesign of services to make things better, etc. The local dentist here was talking to me about an initiative whereby treating children on a Saturday. That works in a number of beneficial ways, in the sense of not having to take the child out of school, and also for the parents as well. And he explained his frustrations at that, trying to take forward that initiative, and being told that he would effectively have to renegotiate his contract. So I'd just like to understand a little bit more about that. Third question. Have there been any liaison between Monmouthshire County Council and Aaron Bevan with regards to the revised local development plan in terms of additional houses within Monmouthshire and how the perceived, therefore, by definition, increase in number of patients in the area. Has that been discussed at all? And my fourth question, more probably information, the brushing initiative in school. You've talked about 10 in the previous meeting, 10 out of 12 have accepted, which is a high proportion. I was just trying to understand, and also 2 haven't accepted, the reasons why they weren't accepted, but equally the positive side of it, why has the uptake been so strong, and what training, this is just information for me, what training goes on with the teachers in relation to this? And given the pressures that are on school finances at the moment, do you perceive any potential reduction in this initiative because of financial school pressures? Hope that's okay, Lloyd.
Yep, no problem at all. So I'll again address those in turn. So in terms of your first question, so there have previously were 12 NHS general dental service contracts being held out of 11 sites. So one practice had 2 contracts. So we had received then contract resignations from Beaufort Park Dental Surgery in Chepstow, and also Thriving Meadow Dental Practice in Mega, with effect of the 31st of August 2024. What we were able to do then was recommission services for all the patients affected by the above changes, but with existing providers. So effectively, the existing providers were able to provide that service. As a result, the total number of now contracts is 9 that is provided out of 9 sites. So the total provision has been re-provided, but in less number of sites and providers that were previously providing. So apologies for that discrepancy that was listed there. We wanted that to be included because we wanted to make sure that it was clear that there had been, because we were talking about the 23-24 year and 24-25, but they resigned midway through 24. So we wanted to make sure that it was clear that they had provided some dental services for that period. In terms of Saturday working, so we would probably be helpful to get some detail maybe offline on this, Tony, in terms of the specific contract holder. I'm not being aware of the contract discussions that may or may not have had a result of that. It does depend whether additional capacity is being requested. So if it's additional capacity that is being requested by the provider to operate that service, or if the provision is moved from another part of the week, for example, onto a Saturday. I will stop and just ask my colleague Rachel if she is aware or wants to come in with any point on that at all.
Thanks, Lloyd. Yeah, I'm not aware of anything. So if we're able to have any specific details, we could look into that further.
Great. Thanks very much.
Thank you very much, Tony. In terms of the LDP, so we hadn't been approached by Monmouthshire Council for an LDP, but in a separate conversation that I had with a member, it was flagged that there was the consultation period that was out and operating. As such, we then formulated a response as an Iron Bevan University Health Board in combination with our corporate teams, but also with our public health team within the Health Board. So we have provided a response into the consultation that's been associated with that. Our key priorities around the LDP really should be that it should be addressing health inequalities, so particularly around ageing population, but also given some of the geographical issues within Monmouthshire, the climate emergency and the impact that might have. Also, what we're keen to understand is how health and well-being extends beyond healthy lifestyles into the wider determinants of health, and how that can be produced and developed going forward, as well as then the particular considerations around what we need to provide in terms of services, how that can be supported, what additional funding we would require as a health board to be able to provide and commission those services, aside from probably picking up Marian's point earlier about having the physical workforce to be able to provide any additional services that are required. So we are very keen as well as that there is a Section 106 agreement that is usually part of the developers' proposals. Often that indicates really about how the local planning authority engages with the health board to understand about what that can support in terms of funding of premises, buildings, etc., to support the delivery. So we are really keen on how we can work with the local authority, but also obviously the developers to understand what can be identified from that agreement to support the population in terms of a service delivery. And then your last question, which was related to the Design to Smile programme and the toothbrushing service that is provided. So it is a challenge in terms of capacity of school staff to support within the programme. We do work in partnership with teaching staff at preschools and obviously the key stage 1 primary schools. And as a result, we do work through whose responsibility is what the training is, and how we can work through it. So there is a significant amount that is undertaken by the community dental service, so they physically go into the premises and support it. Also, they supply all the equipment and consumables to run the programme, so we wouldn't expect any financial implications to be on the school for the ability to provide that programme, but we are aware that it will take time in terms of what is also a very crowded education and training space as well. So it will be a part of the time when they're undertaking the training programme as part of that. No schools have currently indicated to us that time capacity funding is going to likely to constrain their ability to continue to engage in the programme. In terms of the 2 settings, particularly around the primary school, that have had withdrawn, and then the 4 settings for preschool, often they are around the ability for them to work through the consenting process with staff and parents. But where we are currently, I think we're in a very good place where we do have a high percentage of staff and settings that are taking part, and more importantly, a very high percentage of children who are being consented to receiving the treatment for these preventative measures. I hope I've covered off your 4 points there, Tony.
Yeah, you have. Thanks very much, Lloyd. Just linking back to the RLDP thing.
LDP,
The 50, you're probably aware of the administration's requirement for planning permissions for 50% affordable housing, which one might argue suggests that there might be residents moving in who are perhaps possibly in a more vulnerable capacity. Might you perceive an increasing demand as a result of that policy, rather than, i.e. they have less ability to pay for private, and therefore there would be more demand on the NHS dental services? That's the point I'm trying to get across.
Yeah, so certainly. So what we do find is there is a tool which is called the Welsh Index of Multiple Deprivation, so WIMD. So that is the Welsh Government's official measure of deprivation for small areas in Wales. So it goes down to a very localised level. we utilise that as part of our population health needs assessments and plans to understand what the potential demand will be, as unfortunately the higher levels of deprivation broadly will mean the higher levels of NHS care that is required and or to be provided to that population. So we will be monitoring that measure. You will. There is a catch-22 in that 50% are going to be potentially in an area of those housing are going to be those of higher levels of deprivation. The remaining 50% may or may not be. We will be taking an assessment following the development of the programme to understand where that need might be. We broadly will be needing to ensure that our services meet the total population demand that's going to be present anyway. So whether people are in an area of deprivation or are unable to access private healthcare is a separate issue. So we will always be planning to make sure that we're providing for the population that is going to be planned, and we then, as a result, will make representations to Welsh Government where the funding comes to support NHS services to make sure that they adequately follows the population growth in particular areas.
Thank you, Lloyd.
Great.
Thank you, Toby.
Thank you, Lloyd.
Thank you,
Penny.
Okay, Stephen, as another member of the committee, would you like to come in now, please?
Thank you, Lloyd, and thank you for the letter. I think the chair mentioned it earlier, but the letter I received from you in 9th of July last year. I just wondered if I could have, firstly, an update on the impact of the closure of the one contract in Monmouth at Trevunwy Clinic. I think there were 59 people affected by that, and whether there's you could update me on the impact of that's had on those individuals. Secondly, it's a more general one about succession planning, because we had last year the unfortunate closure of the Gilwern GP practice. It didn't appear that there'd been any planning ahead of what might happen to that clinic. So with regard to NHS dentistry, are you looking ahead in terms of clinics where there might be retirements in process, and how those can be mitigated against in the future? And thirdly, it's just, again, another general one about being on the east of the health board area. That I have a sense of being slightly neglected. For example, COVID vaccinations. I've had to take my two sons to Ebervale. I've got an appointment this week in Blaenavon. I live in Monmouth. I work during the day, so I will be at work that day, so I won't be able to attend it. So there are issues with us feeling a bit on these sides of the health board that maybe services aren't as, like vaccinations, but also more generally, services are a little bit less well served here. We've got lots of facilities, but we don't seem to have availability for things like vaccinations in our part of the county. So in terms of dentistry, just to make sure that there is a focus on the eastern part of the county, that we don't get neglected as well, I think is another concern I just want to raise with you. But thank you.
Thank you very much, Stephen. So again, I'll try and take them in the order that you sort of provided there. So just update in terms of Trevunwy Dental in Monmouthshire. So I guess it's helpful probably just to quickly go through a little bit of the background in terms of that practice. So in 2021 to 22, due to a contract variation by which a reduction in the Monmouth area, they were awarded an additional NHS contract. So they moved into having two NHS contracts, and that, as I said, resulted in the practice holding two contracts, the original one plus the additional. Unfortunately, they did have then unexpected workforce challenges and made a decision to terminate the additional contract, but to retain their original general dental contract. So they do still have that general dental contract there, but for any of those patients who were part of the additional contract, that service has been re-provided, and the new practice for that was 7 Dental in Chepstow. So we haven't had any particular concerns, queries, or issues that's come from patients who were previously as part of that second contract that Trevunwy held. They've either finished and completed their courses of their treatment and or are continuing to remain with that practice. It is a complicating factor that, unlike other services, for example, GP services, patients are not registered with a specific dental practice, but they access care through a contract base on their individual courses of treatment. So it is a difficulty in that the patient doesn't necessarily follow the practice, but we haven't had any concerns, queries that has been raised as a result of that. In terms of succession planning, which was your second question. So this is what we do or try to work through as best as we can and try and mitigate for all of the services that we provide. There are contracted services, so whether that be dentistry, GP practice, community pharmacy or optometry. Part of the work that our Primary Care Academy are doing is mapping that out. So we have currently developed what's known as a heat map in terms of our highest level of risk associated with potential age of workforce, but also other factors that may come in terms of levels of deprivation, for example, or it may come in with the number of physical dentists within each practice. So the more dentists you have, the less likelihood that if someone leaves, there will be an issue that will result in a contract resignation. So we are working through that in terms of our dentistry. The challenge that we do have is that often, and more recently, so we've had 4 contract resignations in Monmouthshire in the financial year that we've had, and they've not been related to retirements. And this is the challenge that we have had, really, in that often there are unexpected causes or reasons why contracts are being returned. So we do try and plan for that future workforce, and that's what part of the dental strategic workforce plan that I talked about earlier, I think from Marian's question, plans to do, is to make sure that we have a succession plan for those coming through the system to be able to get into work within the dentistry profession and within the NHS, importantly. So we do map that through and work it through, and as well as obviously the workforce plan, part of that is based then as well on what we look at in terms of the population needs assessment. So, we are mindful that we have an aging population with increased comorbidities, and that will go for dental health as it does for any other health programme. So we know that the services that we're currently providing today are likely to be needed to be greater than what we currently provide to meet the future needs of our populations. And unfortunately, the population pyramid is that we have lower numbers in the working age groups than we do have in the aging categories. So we're trying to mitigate as much as possible what service can be provided, whilst also ensuring our staff want to work in an environment where they're able to provide the care they want to provide to their patients and their population. In terms of your last point then around the east of the region and the services that are provided. So first of all, apologies if you are feeling the impression that services are not as robust or prioritised in comparison to other parts of the health board. And I will certainly look into the vaccination service and where they are providing clinics across the piece. What we do have the challenge within an Iron Bevan University Health Board is matching our services to where the demand is. So we look at a health board approach, and then we look at greatest need based on deprivation, but also demand, and that often means that some of our populations and our services are provided in areas of the greatest level of need deprivation. So you've mentioned Blaenavon, you mentioned the Evervale area, which is broadly a greater area of need than some parts of the other borough. That said, the health board. That said, we do need to make sure that we are trying to provide care as close to home as possible. And Marianne referenced that I was with him last week talking about the work that the Neighbourhood Care Network have been undertaking. So the Neighbourhood Care Network, or NCN, or Cluster as it's known in other parts of Wales, they really focus on how they can provide services within the footprint of the community they serve. So there's a north and south NCN within Monmouthshire, and they actively look at services and how they can provide those services in an equitable way across that borough. And what I will do is pick up with them, particularly vaccination, but also dental provision, to make sure that they are considering that in their plans in terms of how services are delivered, whilst we also look at a broader health board footprint as well.
Thank you, Lloyd. All right, Stephen, are you okay with that?
Great, thanks a lot, Lloyd. Yeah. Just one kind of supplemental. We as members, we all get an email with the engagement from the engagement team, and it explains where they've been that week and what places they're going to. I'd recommend all members, reply to those emails and maybe get somewhere in their area or a group to have a visit, because I think they're very beneficial. I met the team after I had the hip replacement last year, so. But I just wonder whether you get feedback from the engagement sessions and whether that you've had any feedback on the dentistry provision, or whether you are feeding into those kind of engagement sessions and getting feedback, and how that helps you. Thank you.
Yeah, so just back on that point, so I get a monthly report of all the engagement sessions that have been undertaken across the health board, and then high-level feedback for each of the 4 commissioned NHS services. Broadly, we have higher feedback associated with GP surgeries and occasionally community pharmacy than we do with dentistry, but we do have dental concerns that are raised by that forum as well. So, and we do get positive elements associated with it as well. But broadly, what we are working through, and I discussed this probably in more detail in the last session, is the contract is currently under this reform programme, where the traditional model of units of dental activity, so you'll see your dentist every 6 months for a checkup and then treatment, etc., is being moved more towards a needs-based approach via the ACORN assessments as part of the contract reform programme. And when that is discussed with public in these engagement events, they understand the need. So actually, the right people are being seen at the right frequency, as opposed to everybody blanket being seen at the same time. But we are mindful and cognizant that that also feels like people are having less treatment when they are under that service, as opposed to where they were previously. But so there is a comms piece that we are working through with our comms and engagement team, and equally, it's a Welsh government negotiated contract, so they are looking at how they do that on a national basis in terms of sharing that message around moving from a standardised approach where everybody got the same to moving on to an equitable approach where your service is provided based on your needs. So yeah.
Thank you, Lloyd. Thank you, Stephen. Right, I'm going to bring in Louise now, who's standing in for Malcolm Lane as a member of this committee, and that will be followed by Alistair, Sarah and John. Okay, so Louise, please.
Yes, would Alistair be first, because he put his name down first?
No, he's not a member of the committee. So you're standing in for a member of the committee.
Oh, I see, yeah. Okay. Yeah, I've got some questions really as follow-up from the answers previously given. I think following on from Councillor Howell's question about females in dentistry and maternity leave provisions to provide adequate cover in practices. So that's a general question. The second question I've got is about in GP practices in the health board. I think there is sort of a standard of one full-time GP per 2,000 patients, and I wondered if there was a similar type of target or standard in relation to dentistry. The third question I've got is to do with the Section 106 payments. The RLDP gives a priority to 50% affordable housing, and obviously as far as developers are concerned, that takes quite a big chunk of the financial support that they give for a scheme, meaning possibly the less availability of funds for GPs and dentistry. So how would the health board fill that gap? Another question I've got, perhaps too many at this stage. Should I stop there, Chair, or?
No, I'm writing them down, so if you want to finish the questions out, hopefully.
Oh, right, yeah. I mean, the other question is about, the NHS principle of, universal care at the point of delivery. I am a bit concerned that obviously you're targeting those low-income areas and deprivation areas, but in a sense, should not all school children be entitled to have these prevention programmes? You know, obviously you said that there was 12 primary schools and 2 refused for whatever reason. I'm not quite sure what the reason was. It sounds like there's a little bit of capacity there in any event. And, you know, it's a bit like, for example, in England, there's universal childcare for children of the 2-3 age, whereas we have Flying Start, which is just targeted. And I just wondered about whether there was any attempt to look at the universally providing this for primary schools as opposed to just targeting certain ones. Thank you.
Thank you very much. So I'll, as I said, I'll go through those in turn. So first of all, in terms of females working within dentistry, so dentists do have access to the NHS terms and conditions around maternity leave, so they won't be disadvantaged in that way. So they do have access to that as providers of NHS dentistry services. So we and that is one of the draws and the factors that we utilise to support people moving into that area of the profession. So that wouldn't be something necessarily that is available within private dentistry if they were to follow the private practice, but that it is something that works through within NHS dentistry, and they have access to that. In terms of metrics, for GP practices, there isn't a nationally agreed benchmark in terms of number of clinical sessions per patient population. However, locally, we do have a benchmark of 1 clinical session for 200 patients, which is, I think, what you're referring to there. Because the measures are slightly different within dentistry, so clearly the GP practices will be dealing with on-the-day acute demand associated with their practice, but also with service provision more broadly. What we have is, as part of the contract, clear metrics that are services that could be provided, and on awarding that contract, it would be worked through a robust process of ensuring that they do have the workforce available to deliver against the capacity associated with the work with the contract. So it does depend on if they have the standard General Dental Services contract from the Regulations 2006, which is the units of dental activity, which has a set of metrics which need to be achieved, or whether they are part of the contract reform programme, which is a variation on that contract, by which there is a separate set of metrics to work through. But what we do is we support practices to understand their workforce and how they can be able to deliver against their workforce. And if they aren't able to deliver against their workforce, then that funding is brought back in to be able to provide additional NHS dentistry in other parts of the system. Section 106, as I say, is a key factor for us. Now, the challenge that we have as a health board is, obviously, we don't have any commissioning processes around housing. That is not our role. That's not our remit. That is obviously yourselves and colleagues in terms of local planning authority. So the only element that we have is in terms of the Section 106 agreements to be able to support some of the provision. So if there is a new housing development that is created in X area, as a health board, we'll either need to be required to access the Section 106 agreement. Often, as you've noted, we have very limited access to that agreement, and then as such, the provision of services has to come from the fixed pots that we do have and delegated to us as a health board. What we do have is the whole pot for general dental services, as well as GP services, pharmacy services and optometry services, is broken down across Wales in terms of the population sizes. So if we see a greater size of population increases within an Ira and Bevan, that pot will go up as a proportion of the increase that we are seeing. However, it's a singular fixed pot. So unless that pot increases year on year, and the population in other areas go down by the same level that we have, then the level of transfer across the piece doesn't always mean that there's additional funding coming into the system. We have been very fortunate that over several years, the contractual negotiations between those four bodies and Welsh Government have resulted in additional income for our practitioners to be able to access. And as such, we have been able then, as we've been able to maintain the services that we've been providing and or bring in additional services, as I mentioned, really in terms of the additional investments into dentistry that we are committing to in terms of the Bevan Centre within Tredegar and Nightingale Hills within Newport, as I mentioned. In terms of the last question that you asked then around universal care at the point of delivery, and particularly around the Design to Smile programme. So the Design to Smile programme is a national oral health programme that we are interested then to deliver at a local level. The programme is all focused on those areas of greatest deprivation, so areas 1, 2 and 3 on the Welsh Index of Deprivation. Now, if additional funding and resources were available, we would be looking to expand that as much as we could to the wider parts of the population. It is probably a point that is in a similar vein to the conversation that we had earlier around needs-based assessment. So it's around universal care at the point of delivery versus proportional universalism. So ensuring that we don't have what's known as the inverse care law. So the inverse care law is where we have those in greatest needs being the ones requiring the greatest health support, but having less access to it than those in other areas. So we would ideally, if there was the funding available, be able to provide that Design to Smile programme across the piece, but it is focused in those areas of the greatest need, as that's where the evidence base is for the greatest benefit in terms of population management and support.
Yes, Louise, just quickly.
Yeah, just very quickly. Could you explain more clearly the one clinic per 200 that you mentioned? I don't really understand the clinic. I mean, is that once every 6 months, or how does this relate to how often those 200 would get an appointment? So I mean, the 1 to 2,000 patients is an easier to understand concept, and I just wondered if you could explain that in more simple terms, please. Thank you.
Yeah, no problem at all. So I'm not sure where you've got the metric of 1 in 2,000 patients from, but what we do is, as I say, we have a local benchmark, and so this is our localized benchmark. It doesn't, as I said, it's not contractual because there isn't a national benchmark for it, but what we expect our GP practices, and I appreciate we're straying into GP practices in this conversation, but what we expect our GP practices to do is within a month period to have provided a number of sessions that are based on 1 clinical session for 2,000 of their population. So if they had 2,000 patients, we would expect 10 clinical sessions to be provided to try and meet the demand that is associated with that, and that would be scaled up across the piece. I'm happy to maybe pick up offline the 1 in 2,000 question. I am aware that the BMA, so the British Medical Association, do take sort of a poll in terms of average number of patients each full-time equivalent GP is responsible for, and at present that is indicating that if you have 1 full-time equivalent GP at present, they are responsible for effectively 2,000 260 patients. So I'm not sure if it's come from that or not, but it's not a Welsh Government measure or a Health Board measure that we've got one in the 2000.
It came from local discussions that we had a couple of years ago with the Health Board coming to our local forum where we got that figure. Thank you.
Thank you.
Thank you, and thank you, Lloyd. Alistair, I'm sorry to have kept you waiting so long, but it's your turn now, and followed by Sarah and... sorry, Sarah isn't coming in, followed by John. Thank you, and then Sue.
Thank you, Chair, and no problem at all. I appreciate your allowing a question. And Lloyd, really informative. It's been very helpful to hear so many of your responses. I just have a few questions, if I may. Fluoride varnish, is that a game changer? How long does the fluoride varnish last before there needs to be a repeat of that on any individual or any child? In terms of the Gilwern dental services, are we monitoring the impact of the withdrawal of those services on individuals who would have been registered there in terms of their dental care? In terms of the numbers of visits that you've been dealing with over the last year, it's very interesting to hear the numbers. I wonder, do we have information on the percentage of the population who receive no dental care and how that might break down demographically? And separately, do we have any information about those who receive private care, which is obviously a serious cost barrier for many people? And just finally, it's fantastic that we're doing so much, you're doing so much in terms of linking with our schools. But given the level of tooth decay and oral hygiene problems that exists in all ages, but specifically talking about the younger cohort, who would be in school age in one form or another, and giving the links between a lack of oral hygiene and other chronic diseases such as heart disease, stroke, rheumatoid arthritis, and others. We really do need a revolution in dental health care as opposed to doing more of what we've been doing. And I just wonder what that might look like, because if we just keep doing what we've been doing, it's clearly not sufficient. I don't know whether, as a local authority, we can do more to work with yourselves, whether or not there needs to be structured time within schools to allow pupils to actually brush their teeth twice a day at least, and that is built into the structure of the daily routine within schools. I don't know whether we need to do more of going where people go, so be it high streets, be it supermarkets, not on a once every 6 months sort of thing, but in an absolute regular drumbeat of making dental hygiene part of the daily lives of people, and trying to build that into parents and young parents of young children in particular. So thank you. It's a few questions. Some of them are probably quite quick, but I appreciate your time.
No problem at all. Thank you very much. So in terms of, if I've missed any, apologies, but I think I might have them all. So in terms of the first question, just around fluoride varnish, so broadly it is in place for a 6-month period. So the 2 applications would be in that first year, and then same for so that would be the primary school, and then the preschool would be the same process there. In terms of percentage of no dental care and the demographics of such, no, we don't have the data of this, unfortunately, and this is part of why we are supporting the approach of a dental access portal that's going to be able to be provided. So this should provide us, the first time in since the inception of the NHS, an understanding of those who are seeking NHS dental care versus who are accessing NHS dental care, because effectively, it is a holding line of those trying to access care. So we'll have a list there. What I'm hopeful for, and what Welsh Government are hopeful for, is that this will then give us the information to be able to deliver services in the way that we wish to do so. So we'll be able to say X number of people in postcode Y are seeking care, and we can't, there isn't a service there, or there is here, etc. So we can either redesign the services then, as in move in services where the greatest need is, or we can add and commission new services, and clearly that is part of Welsh Government's approach in terms of understanding what the need is, so they can either commit or not funding to be able to provide that. Equally, we do have a challenge around information around private care and the knowledge of who's accessed private care or not. So the very nature of NHS dental private care, as well as any private service provision that you would have, is that there isn't a requirement for that information to be shared then with the NHS, because they're individual companies, private companies. So we won't have the detail of the information that is provided, the services that are provided from a private provision. And there isn't any obvious mechanism for us to be able to capture that either. We are mindful and aware that private services have increased over the last 2-3 years, and part of that is what we know is because some of our previously NHS dentists have shifted to providing only private treatment, but also we are seeing additional NHS dentists, additional dentists just moving straight into the private arena. We are starting to see a bit of a shift change, and this could well be associated with concerns around cost of living crisis, etc., where some of that provision is being reduced, and we are seeing more people coming to the NHS for the demand for the service. But until we have the dental access portal fully up and running, I think we'll be in a position where we won't have at least the data to know about what the demand is versus access. Because broadly, if demand was met with the access, we wouldn't need private provision, but there is a balance that we need to work through. In terms of a revolution in dental care, I completely agree, and this is the approach that I think we need to be working towards too as well. And this is part of the reason the contract is moving to what's known as contractual reform. So I mentioned earlier that the contract originally was based on the 2006 regulations, which is units of dental activity, so people in, people out of the system, so to speak. The movement now, and this has been a sort of a program over the last 3 or 4 years, is being around how we can shift people's mindsets to a needs-based approach, which is what the NHS was founded on, based on around supporting and managing people's needs, which is the contractual reform program. Every year that has developed, and every year that has improved in terms of the ability to make sure the right patients are seen, and they are seen with appropriate timeframes then added for their treatment and support going forward. There is nationally, there are negotiations between Welsh Government and the British Dental Association, so the BDA, and they do work on this programme, and they are likely now to start quite quickly for the contractual year of 25 or going forward around these discussions, and we are likely to see increased shift and move in terms of that revolutionary change to dental care. And I would wholly welcome closer working with yourself and colleagues within the local authority around how we can work on that element, but also about the community dental services that I talked about around schools provision, but also what that service does in addition to going to schools, and the programme associated with Design to Smile is deliver another programme which is Gwen and Bith, which is a programme going to care homes and residential homes to support vulnerable patients within those settings, both training staff but also providing dental services within those areas, as well as community engagement sessions with those sort of at-risk groups that I talked about right at the beginning of the session, such as looked after children, adults with learning disabilities, for example, as well as asylum seekers, refugees, and vulnerable older groups as well.
Thank you, Lloyd. All right, Alistair.
Just if I may, Pen, just a couple of follow-ups, and thank you, Lloyd, very, very comprehensive. it may be, we're not exactly as councillors an army, but perhaps we're a small battalion, and we do go out there a lot and make contact with our communities and individual homes. We pop things through letterboxes a lot, and it might seem a bit of a different way of approaching it, but perhaps we would be able to drop something through letterboxes that perhaps came from us as individual councillors, which can be printed off easily enough, that was really reinforcing the messages of dental care. I see no reason why that couldn't be incorporated into what we do anyway. And we get to, pretty well every property in Monmouthshire over a period. And just the last one was just on Gilwern, and are we monitoring the impact of the withdrawal of dental services in Gilwern on the population around there? Thanks.
Yeah, so I completely wish to take you up on the offer of support around getting the messages out to our communities. So we find that as often a particularly challenging area because broadly the 640,000 patients within an Iron Bevan Health Board that we need to serve. So getting the communications and comms correct, and if we have got the ability to utilise the support of yourselves to do that, then I'd be more than happy to pick that up as part of sort of a programme. And yes, in terms of Gilwern, but sort of more broadly, anywhere where we've had any contract resignations and then the re-provision of services not in that exact facility, we do monitor the situation. So part of that is around understanding from the new contract holder numbers of patients that have presented from the previous location, but also linking with our comms and engagement team. So making sure that we do have a site and a view and a point there. So the Gilwern Community Hall, I was there myself probably 6-7 months ago. We had our comms team there as well, trying to understand some of the impact of the GP surgery, but also dental provision as well in terms of that. So we're making sure that that is in the round as part of the work that we do to ensure that we get the feedback from the communities. And equally, I do appreciate those here who write to us in the Health Board with specific patient views and concerns and/or issues for us to then investigate and monitor, because that's also a mechanism for us to be able to get some of that feedback in as well.
Right, thank you, Lloyd. And I'm sorry we're not giving you much chance to have a drink, even now. We'll forgive you if you want one. John, you're next, followed by Sue, and then perhaps we ought to think about winding it up a bit, unless there's something really outstanding, because I know that Lloyd and Rachel are very busy this morning. Thank you. So, John.
Thank you, Chair, and thank you, Lloyd, for all the information. As Angela and myself are joint members of Mega and Undie, Mega East and Undie, with a population growing very quickly, another development just about to start with another 125 houses and one just halfway through with another 125. Quite clearly, we have an issue for national health dental care. We only have two practices in Mega which are totally full, and it has been your ambition to fulfil the need for the residents, and some of the residents are going to Monmouth and some have been asked to go to Chepstow. But really, it's not working because we have an older population. We have a poor public transport situation, and really we need to look at what we're going to do going forward. And I wondered whether you had any information or ideas of perhaps opening up Kyamore Centre in Caldicot, which would fulfil a great need for national health dental surgery. If you look at the people going from Mega, you're asking them to go to that 7 dental surgery in Chepstow. They have to catch a bus from Mega to Chepstow town, and then a bus service from Chepstow town out to that Thornwell area, and that's really impossible to fulfil an appointment maybe in 2 hours. So there are the issues going forward. I just wondered whether you could put any light on that subject, really.
Yeah, so first of all, I'm not aware of was it the Kyramore Centre you said in Caldecott?
There's an old, it's been there many years, a Kyramore Health Centre, which was the old doctor's surgeries. And I know many years ago, and I'm showing my age now, I suppose, there used to be a dental, National Health dental operation operating out of that area.
So I can certainly look into that particular centre for you. So there are a couple of points probably to pick up. So we are limited through funding constraints, as you would imagine, in terms of contract provision. But equally, we are held slightly to the very fact of practices wanting to be able to deliver services within that area. So if we go out for commissioning of services, we are reliant on the ability of there being practices and dentists within that area who are willing to take on a practice. And we do, where possible, support practices through sustainability funding and support to be able to provide that. But what we are able to do, and what we have been trying to work through, is services of provision that are via our community dental services. So our community dental services do have the ability to do visits to certain locations, but also provide proactive approaches to those of greatest vulnerability. So where you do describe patients or members of the population who are unable to maybe travel to other parts of the system, we do have the options where possible for some of the system to come to them. Clearly, we're not able to bring a dental chair to an individual's house, but what we can do is a lot of those preventative approaches and also assessments that may or may not require the full level of equipment that is worked through. You will appreciate that public transport commissioning is not part of the health board's remit. However, we do appreciate that some of these changes will put people in difficulty in terms of accessing services. So what we do fund and commit to is community transport schemes. So there are a number that operate within sort of the Monmouthshire County. So you're probably fully aware of the Grassroots Community Transport Scheme as something that's a Monmouthshire County Council scheme, but also we do support Bridges Community Car Scheme, which is located out of Bridges Centre, just next to Monnow Vale. So where people do have those transport issues, we do want to work that through with them. For me, it is partly associated with demand, partly associated with funding, and partly associated with the practicalities of having a workforce that are able to deliver services within that location. But I will certainly look at the Kyramore Centre or the health centre, because our community dental service often look for hubs within local communities where they can provide some of the services that we describe. So I'll look into that for you, John, and see what might be in the art of the possible for that community.
Thank you.
Thank you, Lloyd. And last but not least, I think, Sue, sorry to keep you waiting. Okay.
Thank you, Chair, and thank you, Lloyd. I just wanted to pick up on a point made by Councillor Louise Brown, and I'd like to thank her for making it. Lloyd, you'd mentioned that you were looking to provide services in areas where people are least likely to be able to afford private dental care. And I'm concerned about that on two levels, really. One, that we are flying in the face of the initial principles of the NHS of equality of service, but also that is it the slippery slope to providing a two-tier service? I know I personally needed to have some treatment which was not available on the NHS within the timescales because of the standard of equipment that the NHS dentist had. And I'm lucky I was able to afford it. But in order to access treatment at Velindre within a timely fashion, I had to pay for it. And that doesn't sit comfortably with me. So I just want to know what your feelings are around that. Thank you.
So fundamentally, Sue, I want to be able to provide NHS services for our population, and that is the key principle of what we aim to deliver. Where we do have limited resources, where we are currently. What we are not saying is that we're not providing services that are available to all, but what we're saying is that the location of the services might be in the greatest areas of the greatest need to be able to minimise concerns of those patients being able to travel elsewhere, but also to meet the greatest demand. So that might be population. So where I say, and apologies if this, I did say that we are looking to put services in places where people can't afford it. It was more around the level of deprivation, because broadly, what we want to be able to deliver is where the greatest bulk of our population is, and the need of that population to be able to access the services that they can do in a place close to their home and in a timely manner. NHS dentistry has been through a lot of change of late, and unfortunately it is in a different position to where you would have, for example, GP services, where GP services, all of it is funded through the NHS in terms of provision, whereas NHS dentistry, there are still payments that some individuals will have to make for the NHS element of the dentistry provision. This is broader than this health board, broader than myself in terms of delivery. It's both policy direction, but also a Welsh Government management in terms of how we implement the new contract and the delivery of the contract. What I would say is that we have been, and this goes back to Asda Neil's point really, been delivering NHS dentistry since 2006 in a way that doesn't necessarily meet the population need, and we are in a reform programme to be able to meet that need. So we are in that challenging environment, but I certainly would have hoped, and apologies if I don't know the details of your case, so apologies, and I'm probably not in the forum to discuss the detail either, but I would hope that you would be signposted to the right service to be able to provide the need, and mindful that that may not be in your local town, community, etc., but more within where there is the service that is available.
Well, can I just answer that?
Yeah.
I was signposted, but it was a treatment that would have taken 3 months, and there would have been a charge. It would have been about £300. They didn't have the equipment to do the treatment that was necessary, and instead I paid £1,000 and had it done in 1 week, and I'm lucky to have been able to have afforded that.
Okay, thank you, Sue. Thank you very much. Lloyd, I think I'll just ask one question, just a very generic question. What are the main challenges that face you from this point on? What are your main concerns for dentistry?
So my main concerns for dentistry, but main concerns for broadly the provision of primary care services, so the services of GPs, dentists, pharmacists and optometrists, is the ability to meet the demand of our population with the resources that we have. And resources could be workforce, could be funding, or could be even estates, so the ability of buildings for us to provide some of these services out of. We are progressing, I feel, in a positive approach, particularly around dentistry for needs-based provision of services. So from my perspective, really, the day-to-day challenge is trying to make sure that we meet our population's needs, not now, but also not just now, but also for the future population that we have. And I know previously in this discussion I talked about sort of the increased comorbidities and concerns that people are presenting with. So hopefully, as we progress some of these changes, also work with yourselves, but also wider stakeholders, including our population and our Welsh Government colleagues, we should be hopefully in a position where we can be providing the care that we really want our populations to have, and a focus on preventative care so that the need for treatments is reduced in the longer term, because people are remaining healthier and fitter within their own homes or communities.
Thank you. Yes, it's a tall order, but we're getting there. Thank you both so much for coming today. As I say, you've given above the norm to address all the issues that Monmouthshire County Council have had, and what we've required of you. So thank you very much again. I'm sure one day we'll meet, you'll be asked back, but it certainly won't be in the immediate future. So you can rest assured about that. But, if there are problems, and then, of course, we'd like to have you back. Just to sum up briefly, really, because you've covered so much this morning. It's just reassuring that the Dental Strategic Workforce Plan, has and the succession plan is ongoing, and that you're making options of working in Wales more attractive. May be hard to do, but that is reassuring. And also we welcome the Dental Access Portal and its launch on February the 12th. Fingers crossed that it goes ahead. And that our vulnerable and cared for children, I know that Sue mentioned this, and young people are not being forgotten. And the Design to Smile programme is being rolled out in areas of deprivation and need. This is quite reassuring, as is GAB. Is it Gwen Byth? I'm not very good at that. I think that seems to be an excellent programme working in a care home, looking after our elderly and vulnerable. So, you seem to be covering everybody where you can. So yes, the challenges are there, and they seemingly insurmountable, but the progression is heartwarming, really. It is going forward. There are initiatives that really seem to be working. So although it's not the panacea for all evils, dentistry seems to be in safe hands at the moment, and going forward as long as these programs continue. So thank you very much both, and we look forward to seeing you again, but not too soon. Thank you.
Thank you. Thank you very much, all. Take care.
And thank everybody who's joined the meeting to hear this. Now we've just got some formalities, etc., for the committee. So if you'd like to leave, you can stay if you want, but you're quite welcome to leave. So thank you very much. Is that okay? Right. The next thing, Hazel, is the work programme.
Thanks, Chair. At the last meeting, we had quite a discussion about the work programme, quite a long discussion actually, and members suggested quite an extensive list of things that they'd like to look at going forward. So just by way of an update, really, I've been in touch with the Police and Crime Commissioner to see if we can talk about police and resource for the county, and we're looking to try and secure a date. At the moment, we're just in negotiation phases on dates, but that's one definitely that seems to be of interest to many members, and it fits with your crime and disorder scrutiny remit. So we'll be looking to organise a meeting for that. It might need to be a special meeting because you can imagine the difficulty in trying to secure a date with somebody such as the Police and Crime Commissioner. They're very busy people. Similarly, there's also an extensive list of topics from members for discussion with the Aneurin Bevan Health Board. So I've been in touch with them, and we're going to see if there's a possibility to cover some of them off via a briefing paper, because it's quite a long list. But there are one or two, particularly adult mental health and adult suicide, which is something the Chair had felt would be worthwhile bringing to the committee. And I think there are a couple of others around dementia services where maybe if we don't need the Chief Exec of the Health Board, we might be able to get somebody else in to talk to us about those. So those two meetings might be specials. They might need dates arranged according to the availability of the external people. And then the final one is a request that I've had from Councillor Bond. And she has asked that we organise a special meeting and an urgent one to discuss the Regional Partnerships Board's decision to close the Together Work service in Caldicot, which is due for closure on the 31st of March 2025, she suggests. So she has asked that we call a meeting to discuss the cut in funding and the rationale for those decisions, etc. So is that something that the committee would support? Because if so, then we need to organise that pretty soon, and that would be a special meeting.
Sorry, can I just clarify? Did you say she wants a special meeting and it's for Caldicot?
It's for the Together Work Service, yeah.
But affecting Caldicot. So, okay, I'll leave it up to members, but I think that is perhaps a little too specific to have a whole meeting on. Many of us aren't involved with that area. We've got our own, if we all bought that, then what would happen? Yes, it is very relevant, but I do wonder if it could be part of a meeting rather than specific. But please, open to comments. Anybody else got any?
Chair? In view of the fact that there's only a few of us here, maybe it'd be a bit more pertinent to send an email out to see the committee's overall decision on that.
Yeah,
I don't think it's something
I think our next regular meeting isn't until the 7th of April, so it's because there's this time sort of limit, I guess. But I'll email the committee and see what thoughts are. But yes, otherwise these are subjects that are likely to require specials. I have given the 7th of April, which is our diarised meeting, as a potential date for the Health Board or the Police and Crime Commissioner. But as I said, it's quite difficult getting some of these people into the committee. In the work programme, it states flood risk. I think this is really more pertinent to Place Scrutiny Committee, but this committee was interested in attending due to having external providers such as NRW. So if you're happy with this, we can just let you know when Place Scrutiny Committee will be discussing it, and we can invite you rather than having it on our work programme, because it is more pertinent to theirs, and we have got such a list of things that the committee has said they want to look into.
I think Hazel, that really is a place. But perhaps we can have a special, together, joint meeting. Can Steve, can you come in?
I was just wondering whether Councillor Bond's request might be more pertinent to the Seven Side Forum or to the local town council, because they might be able to meet sooner, and therefore, I would expect she'd be able to invite them along to those meetings. That would give her, a more realistic chance of getting that matter aired earlier. And secondly, it was just, I raised a point earlier about the vaccinations. I don't know about other members, but I were getting appointments in my family in Ebervale, Blaenavon. But from a personal point of view, I can get there, but a lot of people won't. And I'm just concerned with the flu vaccinations and COVID that people in our part of the health board area might be excluded from getting to those appointments, and therefore be vulnerable to. We've got loads of medical facilities in Trellick, for example. They've got a health centre which I only found when I was canvassing there last summer. And you think there's all these facilities around. They could be using them for provision of vaccinations, for example. So I think that would be something I'd like to raise with the health board. Thank you.
Yes, Steve, I'm sorry to hear that, because I think in our area, we're pretty much sorted, and they do utilise other areas and chemists, local chemists. If you haven't got that, perhaps why isn't the consistency in approach? So yes, you're right. Okay.
I'll add that to the list.
Yeah, okay. Hazel will add that to the list. And I think your suggestions of Town Council and the Seven Side Forum is ideal, and I think that's much more appropriate than having a whole special meeting for somebody on Caldicot, because I don't think we'll have the full attendance of everybody. So yeah, well done. Okay, next is so is that all right? Do you want to go on one? Yeah.
No, that's fine, Chair. I mean, the Cabinet and Council forward planner is there for members if they'd like to raise anything. It's to let you know what's going on, and if you wanted to talk to a report author, you can contact them and talk to them directly if there's anything you want to raise for scrutiny. I can see Myron's desperate to come in.
Yes, Myron.
Thanks, Chair. Thanks, Hazel. I'm just going to put this next date in my diary, and I've got a planning site meeting on that same morning at 9 o'clock, and also in the afternoon I've got a Democratic Services meeting at 2 o'clock.
What's that?
Monday the 7th of April, so I'm not sure if that's the best date for...
It's the Democratic Services is in the afternoon, but planning site visit isn't listed on the council diary.
Right, yeah.
Last year.
So
I mean, it's just one. I don't know who else is on the planning committee, actually, on this committee as well. If it's just me, then don't.
Phil.
Oh, Phil.
No.
Stephen's on there as well.
Steve is.
Yeah.
Phil has only visited today, sorry. Yes, Steve, so that's two of you.
Has that been rearranged recently?
It's a constant date, that one. It's the first Monday of every month, and the committee meets on the first Tuesday in the afternoon.
First Monday of every month.
Okay, well,
apart from bank holidays, and then they move it to the Friday beforehand.
Okay, generally. It's not in the council diaries here, and the council diaries scrutiny committees have been agreed. Well, it would have been a year ago, because this is like the one from the last diary from last year. We can check.
I'm happy to make my apologies for the meeting if it's just one or two. Well, it's two.
Yeah.
You know, we're not that big, are we?
No, we're not really, are we? Yeah.
No. Yeah, but
okay. I mean, if it turns out that the people we'd like to bring in for, say, the health board can't do the 7th, which I've offered those dates. I mean, it could be that it might be best to just move the meeting.
I'm thinking, actually, it's not essential that the site meetings are attended. You know, I can do the reading around them. So if there was more priority on the public services meeting, then I could make my apologies for the site meeting.
Yeah, I think because they were agreed sort of the year in advance, and it's part of the previous diary. I mean, we'd like to try and bring something to that diarised meeting and keep it if possible, but as I said, we might need some specials as well. But okay, leave that with us. And,
okay.
Yeah.
Thanks.
Okay.
Okay, Steve, as well. Try and sort it out. Okay. Right. Well, the date of the next meeting. Well, you've just heard. We've talked about that, haven't we? So I think we can say, unless anybody's got anything else they want to add, thank you very much for attending, both online and in the chamber. An interesting meeting. So thank you all for your contributions, because you made it interesting. So thank you very much. Okay, bye.
Thanks, Jenny. Thank you.
There we are.
Oh, I've got a new message. What's that?
I need to say that I thought that went really well. There's the technology as well. There's actually more to do, because we've got to set all that up. We're running that alongside everything. The days when we used to just come in and it was actually easier. You know, it's actually hard.